The Miriam Foundation undertook a careful study of the service gaps that individuals affected by ASDs or intellectual disabilities and their families face. A fact-based picture of the situation in Quebec has now emerged. But before we begin to present findings, I will add that we have pieced together available evidence from peer-reviewed journals, grey literature, and many interviews. All of this together represents the best available data we could find within the scope of this study. Some of the data represents our best estimates based on the triangulation of multiple sources. Our findings in no way imply the availability of perfect data, and we sincerely hope that much-needed research continues to evolve in this domain. Furthermore, we welcome any direction from our stakeholders with respect to data that may not be included herein or for which updates may now be available. First of all, it is important to note that ASD prevalence studies among children show an increase of 71% over the past 10 years. This dramatic increase translates to an increased demand for services across the lifespan of an individual, which will only create more pressure on the present system over the years to come. In Quebec, approximately 150,000 residents currently live with an ASD and/or an intellectual disability. Those in need of life-altering services currently face a succession of long wait lists, opaque information, variable quality in services, and financial difficulties that can be catastrophic for both them and their families. In our study, we carefully examined the makeup of this group of 150,000 individuals and honed in on the varying levels of severity and required support across individuals. We have developed 5 subgroups and believe that understanding the various needs of these subgroups can help us, governments, and other organizations in terms of service planning and policy making. To help explain these subgroups, we will provide an illustrative example of an individual who may be a part of each group. The first subgroup includes individuals with mild ASD. These are individuals who can integrate into regular environments with a shadow or other forms of support. We estimate that 20,000 individuals in Quebec belong in this subgroup. Here's a hypothetical example of an individual who might belong in this group. Jonathan was diagnosed with mild ASD. Some have referred to this as Asperger syndrome. His IQ is in the normal range, approximately 100, and he has no language delay. However, Jonathan has difficulty adjusting to social norms and developing relationships, and has had issues at work related to this. He has an exceptional ability to identify patterns across various settings and is very good at drawing 3D models. He likes routine and becomes anxious when changes in his environment occur. He needs support with social skills and is using medication for anxiety. Jonathan lives alone in a small apartment located close to his parents and has recently met a woman at work with whom he shares similar interests. The second subgroup includes individuals who have mild intellectual disabilities. They require targeted childhood stimulation and are able to ultimately integrate into an employment context with support. Approximately 63,000 Quebecers belong in the second subgroup. For example, Anita has a light intellectual disability. She has some difficulty understanding concepts. Anita graduated from a modified high school curriculum and successfully completed a work integration internship. Her IQ is just under 65. She can communicate verbally and expresses her needs well. However, she requires supervision for budgeting and around sexuality, as she can easily be taken advantage of by men in her neighborhood. She has a day job requiring limited conceptual knowledge. Anita lives in an apartment, but her parents help with managing her budget. The third subgroup, which we estimate includes 58,000 individuals, covers individuals that require support throughout their lifetime. These individuals may have more severe ASD or have both an ASD and a moderate intellectual disability. Claire has an ASD and requires substantial support. She has very limited communication skills and needs support with social cues and life decisions. She can perform most self-care activities. She communicates using a picture exchange communication system and at times her iPad. She lives in a residential intermediary home, or an RI, with 4 other people, managed by staff, and attends daily activities at the local community center. She has one topic of interest, that is dolls. She tends to speak repeatedly, and she shows interest in pictures of dolls. She enjoys looking at cartoons on YouTube with the use of an iPad. The fourth subgroup includes approximately 7,000 individuals in Quebec for whom specialized care is required throughout their lifetime for daily living. They may have an ASD, an intellectual disability, or a combination of both. They are lower functioning and profoundly affected by their conditions. George is a profoundly affected individual with both an ASD and a concurrent intellectual disability. He has significant limitations in all domains of adaptive behavior, including conceptual, social, and practical domains, with an IQ ranging between 35 and 45. He has physical comorbidities and uses a wheelchair. George is nonverbal and non-communicative. He requires very substantial support for all aspects of daily care, such as bathing and eating. Finally, the fifth subgroup, with approximately 2,000 individuals, is the smallest and yet in some cases the most challenging subgroup. It includes those with behavioral issues who require substantial supervision. These individuals are often at risk of being rejected from school systems. Daniel is a young adult with a severe intellectual disability. His IQ ranges between 45 and 59. Daniel is nonverbal and non-communicative. Recently, he was moved to a specialized continuous support residence because of his serious, challenging behavior. He has significant self-injury behaviors and now wears a helmet to protect his ears and head. Daniel requires very substantial support due to his aggressive behavior. Our study showed that of the 150,000 individuals with an ASD and/or an intellectual disability in Quebec, only approximately 80,000 of them currently receive any services, leaving almost half without. Here is a breakdown of the numbers of families serviced by the various types of providers. It is important to note that among the 80,000 individuals receiving services, 75% of them, or approximately 60,000 individuals, require a medium to a high level of support. So, now that we have mapped out the population in Quebec living with an ASD and/or intellectual disability, what, more specifically, are the varying needs of these individuals and their families over their lifespans? We have identified 5 critical transition points over the lifespan of individuals with an ASD or intellectual disability, as well as 3 transversal needs across the lifespan that help us to understand all the required areas of focus. The 5 critical transition points over the lifespan that have significant effects on quality of life and the course of life for these individuals and their families are the point of diagnosis, hopefully in early childhood, of an ASD, global developmental delay, and/or intellectual disability. Entry into early childhood intensive behavioral intervention services, or EIBI, that has been demonstrated to significantly increase positive outcomes for individuals and their families. Integration into school. Entry into employment and/or day activities post-schooling, and entry into residential services for some, but not all individuals with an ASD and/or intellectual disability. The 3 transversal requirements across the lifespan are parental support and guidance, parent respite, and specialized medical and dental care. For each subgroup of the population that we have presented, and at every transition point, we have found that there are substantial service gaps in the province of Quebec, both in terms of time to access services and quality or intensity of those services. The same applies for many more locations outside the province, though some of the specific issues and root causes vary. In this table, that we call a heat map, you can see the time required to access service for every subgroup at every transition point. Cells that are red or yellow and make up the majority of the map signify that families are waiting too long for these services. For example, more than 880 children aged 0 to 5 wait up to 2 years for early intensive behavioral intervention or other types of intervention. As another example, only 8% of parents have access to specialized respite, and even when available, 50% of them face long waiting times. As for the quality of services, these vary considerably across transition points, but again, in this second heat map, the results show up as predominantly red and yellow. For example, with respect to early childhood intervention, most subgroups receive much fewer than the 20 hours per week that is considered to be best practice. With respect to schooling, there are many significant issues. As only one example, there are quite simply inadequate and insufficient specific programs in the public school system for individuals with an ASD or a mild intellectual disability in particular. So what's going on? Well, digging more deeply into the example of diagnosis, our research shows that over 1,000 children across the province of Quebec are waiting up to 2 years for a diagnostic evaluation, with wait times varying across the regions. In Montreal alone, since 2007, the average wait times have increased from between 6 and 12 months up to an average between 12 and 24 months, with some parents waiting up to 3 years. The main issues seem to be delayed referrals, lack of diagnostic resources, unclear and inconsistent establishment of roles and responsibilities among the many public sector players, and a lack of common and uniform diagnostic requirements among stakeholders. From an early intensive behavioral intervention perspective, the waiting lists are also too long, as I already mentioned. This has dramatic consequences. Imagine that if children must wait 2 years for diagnosis and another 2 years for early intervention, the available window for early intervention, which should be administered until school age, may actually disappear. This is tragic. Furthermore, our research shows a considerable disparity in intensity of early intensive behavioral intervention. There seem to be multiple root causes of these problems, including the significant and increasing total costs associated with these services due to the large number of individuals in need. Public funding has simply not been able to cope with the increasing demand. There is also limited availability of board certification programs for therapists in this area, meaning that we have an insufficient number of trained resources. The research on school integration shows a lack of qualified resources, with most teachers in regular or specialized classrooms not specifically trained to deal with ASD or intellectual disabilities. Moreover, there is a lack of a coordinated continuum of services. Many publicly or privately funded special educators are refused access to the classroom because of collective bargaining agreements in public schools. In addition to this, there are few specific ASD and mild intellectual disabilities programs developed, leaving it up to each professor to determine what is best to teach. While public schools are, in theory, accessible to everyone, some specialized schools have up to 3 years of wait time. There are only 3 private specialized schools for ASD students and only 3 for intellectual disability students in Quebec. The professor-to-student ratio is 1 to 5 times higher in regular classrooms compared to special classes or specialized schools. The bottom line is that the vast majority of schools are not currently equipped to help these students develop their full potential. Later in life, individuals affected by ASD and/or intellectual disabilities face even more challenges from an employment and day services perspective. At the age of 21, 800 individuals in Quebec exit the school system and have nowhere to go. They are on wait lists for access to employment or daytime activities. 620 people wait anywhere between 4 months to 4 years for employment integration services, and this does not even include all those who are waiting for day activities. There is an important lack of resources in programs, which is getting worse over time, primarily due to cuts in funding of 36% for employment activities and 29% for community integration over the past 3 years alone in the province of Quebec. Moreover, there are not enough funds to subsidize company salaries for individuals with ASDs and/or intellectual disabilities. From the residential services perspective, 1,400 adults are waiting up to 11 years to have access to residential services in Quebec. And this does not include the many families in need of residences who are not yet on any wait lists. Residential services currently take up nearly half of the Provincial Health Ministry's budget for ASD and intellectual disability services. And demand is still not being met. Private options, costing anywhere between $30,000 and $40,000 a year, are beyond the reach of most families. Thinking about the future, the numbers of those in need will only continue to increase. Overall, the system is simply not equipped to deal with the pending upsurge in clients, given how many people have been diagnosed, with ASD in particular, over the past 20 years. Returning to the 3 transversal requirements for families throughout the lifetime of their loved one, parents face a series of other issues. They need access to service coordinators to guide them through the complex and fragmented system of caregiving. Technically speaking, service coordinators do exist across agencies. However, few parents have ready and continual access to service navigators throughout the lifetime of their child as the needs change. And even when they do have access to service navigators, many of them are overworked, lack ASD or intellectual disability specific training, and do not have the authority or resources to push cases through the system. Parents do not know where to turn for reliable information and often rely on word of mouth. No standardized information is provided to parents following diagnosis, and it is impossible to know how many families in total are in actual need of services, as many do not even sign up at their local community service center. Overall, with respect to financial support for families, there are options directly available to them, but the amounts are small, and the application processes can be onerous. For example, a family with a $40,000 a year income level would receive just under $4,000 in total per year in child assistance, which does not even begin to help cover a portion of the many services we've discussed that parents often pay for directly. To provide an example of the findings of Dudley and Emery in 2014 from the School of Public Policy Research Papers at the University of Calgary, the authors note the following. An autism diagnosis of a high-needs child at age 2 represents the equivalent of telling the family that they must make an immediate lump sum investment on that day of $1.6 million, invested at a 5% return, to pay for the lifetime costs of care and support their loved one will require. And that amount does not even account for added professional services, such as speech therapists, psychologists, and occupational therapists, or additional out-of-pocket expenses that may be required, such as special equipment or diets. Parents need breaks from the continual burden of care, yet only 8% of parents have readily available access to specialized respite resources. Current subsidies for respite are insufficient to meet families' needs. Many respite providers must put limits on the allowable number of weekends per family due to their own limited resources, and most services must use a one-size-fits-all approach, whilst individuals requiring these services have different needs, as we have shown. Weekends can cost $70 to $150 per day, and caretaking can amount to $75 to $160 per day. Government subsidies, on the other hand, are based on an average salary of $3.50 an hour. This is all based on a report by Quebec's Auditor General. Direct governmental allocations are clearly not sufficient to cover family needs. Finally, there's a lack of resources in terms of individuals trained to provide respite care. There are insufficient budgets to hire, train, and retain competent resources, as well as a high turnover of employees of respite service providers who often tend to be transient students. Looking at specialized medical and dental services that are needed across one's lifespan, a few key facts demonstrate that even though individuals affected by ASD or intellectual disabilities are particularly vulnerable to a number of medical conditions, most families struggle to find specialists who are able and willing to care for patients with these special needs. The Canadian Digestive Health Foundation reports that the population with ASD has a prevalence rate of gastrointestinal problems 49% higher than the regular population. The rate of epilepsy is also higher in ASD patients than in average populations. Since many of these individuals are not being seen, individuals with intellectual disabilities, for example, have on average 2.3 unrecognized conditions and 2.7 unmanaged conditions. Moreover, one study showed that hospitalizations for conditions that are theoretically manageable, for example diabetes or asthma, for patients with an intellectual disability were 186% higher than the regular population. People with intellectual disabilities have also been shown to have poor dental health. Several issues may be impeding medical and dental service access and quality. First, the financial incentives for care providers may not be in place for treating patients with ASD or intellectual disabilities, even though their visits are lengthier. Second, there's no place for families to learn about the available specialty medical and dental services. Third, patients with ASDs or intellectual disabilities often have difficulty discussing their symptoms, which leads to diagnostic overshadowing. Finally, few doctors receive training on how to adapt their habits for ASD and intellectual disabilities. In a nutshell, as you can see, though many stakeholders have long argued about the severity of issues related to ASD and intellectual disabilities, we now have a deeper understanding of the population in Quebec living with these, as well as the extent and nature of the issues faced by individuals and their families. This research has helped us prioritize and further specify our own activities moving forward.